Thank you, Mr. Chairman, and thank you for making these fast adjustments. My Surface, the Windows decided to do a last-minute 45 minutes upgrade while I was doing the last touches of the presentation. So these are my disclosures. I'm here to talk about RAPID and its role in patient selection and research. And there's no question that RAPID has made some critical contributions in our understanding of pathophysiology of large vessel occlusion stroke. And we have several prospective, very important trials, some of them randomized, that you all know about, that have shown that when you select patients based on RAPID, there is significant clinical benefit from reperfusion. So RAPID has been and automated perfusion imaging has been a very important development in the field of thrombectomy. However, there are some limitations and some questions that we need to ask. First of all, what do we know about RAPID? So, in terms of RAPID as a tool, as a brand, over and beyond automatic perfusion imaging. So RAPID generated mismatch assessment has the highest degree of clinical validation. There's no technology that comes even closer to the amount of clinical validation that RAPID has behind it. We know that the core is reasonably well estimated by DWI MRI, and that on CTP, core does not that well with estimation, although many will argue it's good enough. The thresholds for core and penumbra, we find that more and more increasingly are dependent on time to reperfusion on CT perfusion. The presence of mismatch is associated with clinical outcomes after reperfusion, but proof of mismatch does not necessarily require perfusion studies. Dawn has shown that you can derive as strong clinical benefit if you use the clinical core mismatch. So it's not clear that you absolutely need the perfusion study for patient selection. And in the early time window, benefit from thrombectomy is not dependent on selection based on advanced imaging. There's been many trials that did not use advanced imaging and that have shown substantial benefit from reperfusion. There are things that we don't know. First of all, whether absence of mismatch is associated with no benefit after thrombectomy. We have no data that if you have no mismatch, you won't benefit after thrombectomy. We don't have no data whether absence of mismatch is associated with harm after thrombectomy. And we don't know whether benefit with thrombectomy in the extended time window requires advanced imaging. We don't know what is the patient population, if any, in which selection for thrombectomy based on advanced imaging is absolutely necessary. Are there any patients where we absolutely need to do advanced imaging? These are things that we need to answer through trials in the future. And whether advanced imaging is actually harmful in certain patient populations, because we don't understand very well the true price we pay in terms of wasted time to reperfusion when we perform these advanced imaging studies. This study shows that the thresholds that we use in these automatic, whatever these automatic perfusion softwares are, we use thresholds for core and penumbra. They're derived on CTP or CBV, less so, but mainly CTP values. For penumbra, we use Tmax values, and all these thresholds are actually, we're finding that out. As we open vessels faster, we find out that all these thresholds are dependent on time to reperfusion. So this is a moving target. We have not figured out yet exactly what these thresholds are. It's an imprecise science. This is, again, data, very recent data from the Hermes group showing that there is a significant relationship between CTP to reperfusion time and these optimal thresholds for core and penumbra. And then, even when we have these large cores, do we really know that reperfusing these large cores is associated with lack of benefit of harm? This is data from Hermes. We all know about the Bruce Campbell paper from Lancet Neurology. Some of the Hermes patients had CT perfusion studies at baseline, small number, it's true, but the trend is very clear. There is a significant benefit for patients with baseline cores of greater than 70 cc's. And as I will show in the next slide, even patients with greater than 100 cc's, the trends are in favor of benefit. And very important to also understand that not only there's benefit or strong signals of benefit in these patients, but these patients are actually very rare. So patients with large infarcts in Hermes, 95% of patients had mismatch, and 78% of patients had large penumbral volumes of greater than 60 mLs. So do we really need to do these studies when we waste time doing them? Again, this is the trends towards better outcomes in patients with cores greater than 100 mLs. Of course, all patients in general have poor outcomes. Large core is a poor prognostic factor, but it's not clear there is a treatment effect differentiator. And then how much time does it take? That's something that I haven't seen and I'd like to see in all these studies that use CT perfusion or MRI at baseline. There is no study that I know of that has calculated how much time we actually take to do one of these studies. The only thing that comes close to that is Swift Prime data, where the time from plain CT performance to successful post-processing of CT perfusion imaging was 24 minutes, okay? So, and then if you do an MRI scan, that sets you back 16 minutes longer, right? So how much time do we actually spend by doing these advanced imaging studies? Because it's important to know, because for every 15 minutes that we move faster, we have, per 1,000 patients, we have 39 patients with less disability and 25 patients more with functional independence. And as Mark Rebo showed in this paper based on Reva Scott, the fast progressors, the patients with poor aspect scores at baseline, are the ones who suffer more, who have the worst consequences of time delays. These are all comers. These are aspect score less than 8 with a very steep curve of time to reperfusion versus outcomes. And these are patients with good aspect scores where there's actually no relationship. So it's really the fast program. And if we do imaging, as Mark again has shown, we pay every single imaging step, even if we take the patient directly to the CT scanner versus going to the angio suite directly, bypassing any imaging, sets us back 42 minutes. So by doing imaging, do we pay a price in terms of outcomes? So in the early time window, sort of my summary is that rapid and advanced imaging, there is no evidence or any kind of CT perfusion or advanced imaging. There's no evidence that it's necessary. We need to clarify where it's in fact harmful. Fast progressors are punished the most, and given time expenditures, in my opinion, there are ethical concerns about performing trials requiring advanced imaging in this time window. In the extended time window, we know that we pay a much smaller price for taking our time to do imaging studies, but the question is, are these imaging studies really necessary? We know now that we don't really need to have precision in delineating core. Whether the infarct is 10 cc's or 30 cc's, it's irrelevant. The patient needs to be treated anyway. All we need to know is, does the patient have a giant infarct? Does the patient have an infarct that is less than 70 or 100 cc's? And not even that is clear. So based on several studies. This is a paper from Australia looking at CT perfusion correlation with aspect scores. It seems that when it comes to aspect scores, being able to discern a large infarct, 70 cc's, it's about the same as CT perfusion if you compare it with a gold standard, which is an MRI. And when we treat patients based on CT alone, aspects, this is data from the TRIVO registry, beyond 8 hours, patients who are selected based on CT perfusion in TRIVO registry didn't do any better than patients who were selected based on CT alone. So the important trial question, in my opinion, is to clarify whether even in this extended time window, advanced imaging is necessary. And then we have a lot more work to do because we have these giant treatment effects in DAWN and DIFFUSE-3. We clearly can go lower in terms of baseline core volumes, and that is something that we need to establish further in future trials. So I think I'm sort of optimistic. There are new approaches with rapid, with a lot of other post-processing software products that were mentioned here. And that is encouraging because it kind of moves the whole field from imaging towards workflow. And I think that's kind of where the money is in terms of getting better outcomes. The automated large vessel occlusion imaging, the automated aspect scores. I think I would welcome if the field develops kind of in this direction. Thank you very much.